Yes, welcome to the channel. Today I'm doing a short video after a long time of being away. Just talk about some things. We had a very rough time last time because of work and some issues, and we covered something on management of diabetes. We went through the pathogenesis, how diabetes comes around, and we saw we saw how to manage diabetes and how at least to go about not to get it. So today I'll do a very short stream to cover complications of diabetes. Now, so complications of diabetes, what are complications of diabetes? You see, you have to sometimes when issues become so hard, sugars are high, and you cannot manage them well, some complications come in. These are the complications that we need to handle, mostly of type 2 diabetes. There are two types of complications, namely, we have one which is acute complication, and we have the other which is chronic complications. These complications arise due to chronic hyperglycemia. Hyperglycemia, we talk about high sugar levels. So, anytime you hear me talking about hyperglycemia, just know I'm talking about high sugar levels. Insulin deficiency. Hmm? Uh, Insulin deficiency. We have talked about insulin deficiency and how insulin is produced for so long. Resistance, deficiency and resistance, and metabolic disturbances. They broadly categorize into acute and chronic complications. Yes, so acute complications most of the time of diabetes comes in as this occurs. Let me see. Yes, these occurs can be life-threatening. Suddenly, you just start having a life-threatening period, like diabetic ketoacidosis. We talked about it, but we are going to talk about it here again. Pathophysiology of diabetic ketoacidosis, and then we go to um, features of diabetic acidosis, and then we have another one called hyperosmolar hyperglycemic state. HHS. Common, more common in type 2. We will see the pathogenesis, pathophysiology, how it comes in. And then we have hypoglycemia. Hypoglycemia, like low sugar levels. Low sugar levels. You see, complications of diabetes can be two-way. It can be high sugar levels, or you can get low sugar levels according to what is happening. So hypoglycemia can result from insulin anti-diabetic drugs, missed meals, excess exercise. You see, those ones we will see. And then now in complications, we have said we are categorizing them in two types of complications. Yes, my tennis is Sky. Very long time. I haven't been online for some time. So today, I'm going through complications of diabetes. Welcome to the platform. Let's learn a little bit. Yes, complications alone, and maybe we will learn how to manage the complications. Now we have two way of complications: acute and chronic one. Acute are sudden, and short. Chronic are prolonged. Now, prolonged complications of diabetes. These are chronic complications like result from prolonged hyperglycemia. When you have prolonged high sugar levels, when you have a prolonged high sugar levels, you get microvascular and macrovascular. Vascular means small vessels, small blood vessels, or vessels in your body, like eyes, kidneys, and nerves. They suffer. Those are microvascular. So in chronic, we categorize them as macro and micro, chronic complications. And then we go to Microvascular, what can happen when you have high sugar levels for long? Hmm? You can get diabetic retinopathy. Hyperglycemia damages the retina microvascular. It damages it. And then we have diabetic nephropathy. Diabetic nephropathy is a bad thing. Yeah? Glomerular basement membrane thickening, mesangial expansion, and glomerular sclerosis. This one is in the kidney. So for diabetes, you can get a problem in your kidney. You see? Yes. Yes, yes. Please introduce that person to my channel. Let that my Tennessee guy. Let that person start on diabetes. The introduction of diabetes to go slowly and listen. It will really help that person. Please send that person a link. Tell that person follow up on this topic of diabetes because we have come from so long. Now we are categorizing chronic complications. Microvascular, we have said this one affects small vessels like the eye, kidney, and nerve. And then we have diabetic nephropathy. This one affects the kidney inside, yeah? The microalbuminemia, mesangial expansion, glomerulosis, all those. Diabetic, we'll look at them step by step. And then we have diabetic nephropathy, mechanism, microvascular ischemia, subtotal accumulation in lungs. You see, we have now the bigger one, macro complications. In chronic, we have said we have small and big. So micro, we have said are small elements like the eyes, you get it? The eyes, kidney, nerves, those are micro, but we have the bigger one, which is macro. So macro complication comes in with heart diseases, cardiovascular diseases, increased risk of coronary arterial disease, cerebrovascular. We will see how these issues come in. Peripheral arterial disease. So we categorize them into three: acute, chronic, but in acute we have in acute, we have DKA, which is diabetic ketoacidosis, HS, and the second one is HHS, hyperosmolar hyperglycemic state, and then the third one is hypoglycemia, low sugar levels. You can be a diabetic, but your sugars are going down. That is a complication. And then in chronic, prolonged, we have chronic complications that affects, they are categorized into three: micro complication, small vessels like eyes, kidneys, and nerves, and then we have macrovascular complications, affects large vessels, accelerate like cardiovascular diseases, heart diseases, stroke, peripheral arterial diseases. I'm just rushing. And then we have other chronic complications like diabetic foot, infections, skin change, and dental issues, periodontal. And then we have the last one, which is complications in pregnancy, diabetic mother. I think that one, it will be a topic on its own. Now let's start with this one called acute complications. And in acute complications, the short-term complications of diabetes, we have the first one, which is called diabetic ketoacidosis. Diabetic ketoacidosis. What is diabetic ketoacidosis? Is an acute life-threatening complication of diabetes mellitus, and it comes with these things: hyperglycemia, that is high glucose of 13.9 milligrams per liter and above; ketoacidosis, accumulation of ketones, low blood pH. You see, ketoacidosis, accumulation of ketones, ketonemia, and ketouria. And sometimes a person is dehydrated. You get dehydrated and you get electrolyte imbalance. Now, what is electrolyte imbalance? This is your sodium in the system, your potassium, all those alkaline phosphate, they are deranged. So you don't have a balance of the electrolytes in your body. What happens? You can start swelling the feet. It is the most in type 1 diabetic ketoacidosis. Most type. So what happens here is this, my friends. You see, what happens in diabetic ketoacidosis, the first complication, insulin deficiency, absolutely relative. Increased counter-regular hormones, glucagon increases, cortisol increases. You see, cortisol is like a steroid that your brain produces, and catecholamine and growth hormones. They trigger infection like pneumonia. Common triggers that may cause this are like infections, pneumonia, UTIs can trigger high blood glucose. You get it? Missed insulin dose. You forgot to go to get your dose. Hmm? Poor compliance of taking your dose. It's very bad. And then myocardial infarction, stroke, pancreatitis, trauma, stress. We saw how stress can bring about these problems. Certain drugs like corticosteroids, thiazides. Thiazides, we are talking about a drug like HCTZ, hydrochlorothiazide, sympathomimetics. Those ones, some drugs that can make you get sympathetic nervous system. So how does it come? Insulin resistance and increased counter-regular hormones. Hepatic, they make the liver to produce more glucose and gluconeolysis. You see, glyconeolysis. So if the liver is producing more glucose and some other process is going on like breaking down of your cholesterol and fat to produce more glucose, it comes up to be high glucose level in your system, hyperglycemia. Now, reduced glucose uptake in the muscles and fats, because we saw the work of insulin is to take glucose to some muscles and fats. You get it? And it worsens high sugars to go up. Now, this motivates lipolysis. What is lipolysis? Breakdown of fats like triglycerides. Increased fatty acid. Free fatty acids in your body are increased. In the liver, fatty acids, ketone bodies, acetate, acetone, beta hydrobutyrate. You see, it's all, let me just call it acetone increases. Accumulation in your body, it makes you get metabolic acidosis because you cannot get balance the sodium, you cannot balance potassium in your body, you cannot balance the glucose. So it become an acidotic state. Hyperglycemia, you get something called osmosis diuresis. Diuresis, going to the loo every time. Polyuria, you urinate. Dehydration, you get dehydration. Electrolyte loss, you start losing sodium, potassium, and you know potassium helps your heart. Magnesium phosphate, if you lose more potassium, your heart will you will not balance, you will have some things called tachycardia. So you see, these ones, how they come: insulin deficiency and other hormones coming in. They increase glucose production from the glycogen that was stored in the liver. And then you start breaking down your fats that are in the body so that you create more glucose. And you see, by breaking down fats, what comes in, you get ketones. Ketones are toxic when they are so high. They bring some things called acetone in your body. So if they bring acetone, what happens? You start having problems, piling, sugars high. You start being dehydrated. Yeah? The electrolyte, sodium is not there, potassium is deranged, your heart is beating irregular. Yeah? You see. So acidosis plus electrolyte imbalance, because your sodium, potassium, and magnesium are not balanced at this state. What happens? Your brain cannot function well. You start being something else because now your brain has no balance in, you see, encephalopathy, we call brain damage, arrhythmias, your heart beating, because now potassium is not balanced, your heart beats, and then you end up in shock. So when you're brought to the hospital, the first thing is we balance electrolytes. Now, what will make you know that this one is diabetic ketoacidosis? This person will have polyuria, polydipsia, polyphagia, and weight loss. You are eating too much. You are eating too much and you are not gaining weight. Eating too much, no gaining weight, and you are going always in the loo every time. You drink water, it just passes polyuria because there is no sodium, there is no any salt to protect the, you see, excessive urination, polyuria, excessive thirst, polydipsia, you are always thirsty, polyphagia, hmm? excessive hunger, weight loss, you are eating but you are getting weight loss. You see, diabetic ketoacidosis. Because now weight loss is because your body is cutting down the fats every time, and then you end up having nausea, vomiting, abdominal pain because increased hormones are not balancing with the the insulin that is coming out. Fatigue, consciousness, and drowsiness is always there. Steve and Tina Jewel, welcome to the platform. Welcome. We're talking about diabetic ketoacidosis, complications of diabetes. You see, so what are the signs? Because the symptoms are different from the signs. This is a complication. Now, symptoms is polyuria, polydipsia, polyphagia, and weight loss. You eat, you are not getting weight. You are eating, you are not getting weight, and then you are urinating a lot. So what happens? What are the signs? The signs of dehydration. You are dehydrated, dry mouth, poor skin tagger. When you touch the skin, it's so floppy. The skin is so floppy. Your pressure down, always low pressures, and your heart beats so fast. We call it tachycardia. Heart beating so fast, we call it tachycardia. Kushmo respiration, deep labored breath. That is what we call Kussmaul. A person is in bad state, Kussmaul, because there is no regulation of glucose. It has ended up to destroy the electrolytes. Fruity odor breath, acetone in your, you smell that person in the mouth, there is a fruit. You feel like he had taken some juice, and it's not that. And then we have altered mental status, stupor, coma. You get it? Now, we continue with when you get to the hospital, they look glucose, arterial pH, we see serum bicarbonate because of the electrolyte imbalance. They will do kidney function to see sodium, potassium, you get it, before you start getting the IV. Now, this is the complication that all the diabetics that are not following treatments get. Diabetic ketoacidosis, they get to the hospital when they have lost conscious because of electrolytes imbalance. Their sodium, their potassium, everything is deranged. Sometimes you can, if it ends up bad, you can get someone with cerebral edema. The brain swells, cardiac arrhythmias, problem with the heart because of electrolyte imbalance. Mostly when you have been losing potassium so much. So those people that are using diuretics are drugs that remove water in your system. It is better you use potassium sparing diuretics like spironolactone because that one will keep potassium. But if you use something like furosemide, it will remove everything. Acute kidney injury is there, complication. And times if it is not taken carefully, you see, left not untreated, this person will die. So we see the management, airway, breathing, circulation, insulin therapy very fast. You give insulin 0.1 units per hour as you per kilogram per hour. You calculate 0.1 per the kilogram per hour. It goes to an hour because now the sugars here are high and we are planning to bring them down. That is for medics. Yes. Correct acidosis, monitor potassium replacement, very important. Insulin therapy is very important here. This is a state of emergency. You get it? So that one is the first acute complication when it comes to diabetics. It is a short, very bad period because everything is deranged. So when you go to the hospital, and then you get home, not the hospital. Someone is smelling fruity uh, taste in the mouth and is unconscious. That is an emergency. Do what? Run very fast to a doctor. Now we go on to hyperosmolar. If anyone has a question, pin it down. We see what is going up, what is going up, because you want to help some people that have problems with diabetes here to understand themselves. Now we go hyperosmolar hyperglycemic state. What is that? Is an acute life-threatening complication of diabetes mellitus, characterized by severe hyperglycemia. You mean your glucose goes high, like wow, you get it? That's some drugs here that this your your sugars just strikes up. You do sugar levels, they are beyond. They are 600 milligrams per deciliter or 33 millimoles per liter once, maybe because of shock or stress. Hyposmolarity, when they do it, they get it to 320 osmol. And then you are severely dehydrated immediately. Minimal or absent ketoacidosis. Now, here, because it is acute, you will not get ketoacidosis a lot. You get it. It occurs in type 2 diabetes, often in elder patients that are sometimes getting infections, poor diabetes control. You are a diabetic, and when you get a wound, you don't treat the wound well. When you get some respiratory diseases like flus, bacterial or viral, you don't treat them well. Then sometimes some people will are diabetic and they have something called myocardial infarction. Myocardial infarction is problems with the heart, infection, trauma, surgery, drugs, like you are diabetic but or you are on corticosteroids and thiazides, phenytoin, beta blockers, and antipsychotics. These are drugs that anti-diabetics should be monitored when they are on, or they should not be taken by diabetics. Corticosteroids, steroids, thiazides like HCTZ, hydrochlorothiazide, phenytoin. You see, phenytoin are those are anticonvulsants. Anticonvulsant. When you have a convulsion, then you get phenytoin, and then you have a nerve stabilized, and then you are okay. But if you are a diabetic, tell your doctor, I'm a diabetic, I don't need phenytoin. I know it will destroy it and hit me to get to HHS, hyposmolar hyperglycemic state. Beta blockers, those ones that are helping the heart to beat slow, and the people that have anxiety issues, stop taking if you are antipsychotics. When you go to a doctor and then you have been given antipsychotics because they think something wrong is happening, you should be monitored. You see, now relative insulin deficiency, not enough to present hyperglycemia but enough to suppress ketogenesis, not significant ketoacidosis. Now, what I'm saying is you have insulin, not enough to bring down sugar, but the insulin you have stops lipolysis to ketones, production of ketones. That's why the sugars are high, but you are not so bad. You get it. Hyperglycemia, severe osmotic diuresis, massive water and electrolyte loss. You urinate, my friend, every time to the loo, every time to the loo. Dehydration. You see, if you urinate so much, what happens? Dehydration comes in, hyposmolarity, altered mental status. Your mental status goes, you see, seizures and comas will always be seen in this state. It's a very fast thing, but you can get a coma within some 20 minutes. You see, so the complications are normal like the other one. Polyuria, urination, polydipsia, hunger, weakness in the body, confusion, lethargy, stupor, seizures can occur because now you have electrolyte imbalance, and coma. You just get into a coma. Pap, because this is a very high sugars, no electrolyte imbalance, your brain can swell immediately. So you see these things, guys. When you are a diabetic, you should be following yourself with drugs and doctors and advices and following the right advice, so that you cannot get to diabetic ketoacidosis and hyposmolar state. You see, this one management is to bring down the sugars and rehydrate. Only that. Stabilize the electrolytes so that this person may come back to life. Like you give normal saline, sodium chloride to the system as you take kidney function test to see how the kidney is working. Now, here there are two different types of we have talked about diabetic ketoacidosis and HSS. It is quite like confusing. But look here, the difference between DKA and HHS type of diabetic, mostly DKA is in type 1 because they don't have insulin enough from childhood, and HHS, hyperosmolar hyperglycemic state, is in type 2. You get it? Onset of diabetic ketoacidosis is faster, but in high sugar levels, HHS is slow. Glucose levels 250 milligrams per deciliter, 13.9. But in HHS, my friend, because it comes like power, your sugars strike like bah! That one goes up to 600 milligrams per. Yes, welcome, Roger Killer. We are talking about this one is called difference between diabetic ketoacidosis and HHS. These are complications of diabetes. When you go to your house and find someone is there confused, he can't talk to you and is a diabetic. You is either suffering from DKA or HHS. You get it? Now, we have bicarbonates, 18 millimole, and the other one less than 18 millimole. HHS bicarbonates are less than 18 millimole. We have ketones, positive serum in urine. Even in urine, you get ketones. But in HHS, because the sugars have come like power and they have not destroyed some issues, you will not get. You will not get. Now, in diabetic ketoacidosis, we see total body deficit in potassium. But in welcome, Robert Killian. But in HHS, it is same, but usually more profound deficit. You see, now you've seen the difference. So when you get a diabetic lying there, look at several things like cell onset. Did it start slowly or fast? You will know if this is ketoacidosis or HHS. You can start managing it from home as you rush to the hospital. Now, diabetic ketoacidosis, a hyposmolar state, but now we have a funny thing. This is a funny thing. Let me call it funny because we expect in diabetes to have high sugar levels. But now, what brings hypoglycemia, low sugar levels? You can get someone is a diabetic, but the sugars are low. Find funny, that is bad because that person can go because the sugars are low and no one is around to help this person because he's weak, he can't go to work. So hypoglycemia means abnormal low blood glucose levels, very abnormal low blood glucose. In adults, less than 70 milligrams per deciliter. That is 3.9, like fasting blood sugars. You see, hypoglycemia 54, 3. You wake up with 3, you eat, it goes up. But now, causes, what are the causes? It happens more in elderly people. But what are the causes? In people with diabetic, they sometimes do excess use insulin. The drugs like metformin, especially sulfonylureas and maglitide. You take a lot of drugs and you have missed meals. Your sugars will go down, my friend. They will go down. Yes, because you are not balancing the, the meds that you are given by the doctor. You get it? Excessive physical activity without adequate food or insulin adjustment. We saw exercise gives us insulin. They motivate insulin production. You do exercise and you forgot you are a diabetic. Then you go home, you take insulin or those drugs. Your sugar goes down. Woo, whoosh. Yes. Hmm? And then alcohol intake. Hey, alcohol intake inhibits gluconeogenesis. Hmm? When you take alcohol, it stops you from producing glucose from glycogen and fats. So sometimes your sugars may be nil. I'm not saying that people to drink alcohol that are diabetics. No, it is a bad thing. You can end up to have DKA. In people with diabetes, fasting hypoglycemia, insulinemia, pancreas beta cell tumor, fasting hypoglycemia, it is linked to a tumor that can be growing in your pancreas. It is called pancreatic beta tumor. Get it? And then we have critical illness like sepsis. Sepsis is normal. Bacterial infections, those are sepsis. You get it? Sepsis are like bacterial infections and renal complication like pyelonephritis, heart failures. Your heart failures like myocardial infarction, rheumatism, those one can cause you because they are live pathogens. There are bacteria and viruses working on you, and then your sugar goes down. Hmm? Hormone deficiency like adrenal deficiency and hypopituitarism. The pituitary gland is not functioning as it should be functioning. You see, guys, these are so many. There are things that at times we look at, and then we should follow up to our relatives, and at times us also we should follow up. Reactive hypoglycemia after gastric surgery, early diabetes, and then alcohol induced hypoglycemia. Taking alcohol, pathophysiology, how it comes is this: brain relies on glucose as its main source. Low blood glucose it reduces autonomic nervous system activation. Hmm? Direct neurological effects like brain dysfunction. You see that? Now, clinical features of this is Whipple trial used for the symptoms of low sugar levels, documented low blood glucose, relief of symptom after glucose. You are given glucose or a sweet and then you start feeling better. Eh? Adrenergic due to catecholamine release. Sometimes you feel sweating, tremors, palpitations, anxiety, and hunger. Hmm? Neurology, coping due to brain deprivation. Sometimes when the brain is disturbed, you will get headache, dizziness, blurred vision, you are not seeing well, and then confusion, irritability, slurred speech, seizures, and coma. You get it? Now, these are the complications. They are managed where in hospital. But if you get someone has no strength and you have that thing at home to measure the glucose and you're seeing they are down, as you take this person to hospital, take some sugar or a sweet sugar or a sweet drink, give this person so that he starts to create glucose as you go to the hospital. So we talked about the other ones are management in the hospital. Now we talk about the chronic complications, the long-term complications. And then there is one complication that I will talk about tomorrow alone. It is the diabetes of a mother after getting a baby. That one, we will talk about it tomorrow alone. Now, the chronic complications, we have micro, and macro. So here in chronic complications, what is micro complications? Micro and small vessels complications like the eyes and nerves. What happens here? Mm? Microvascular complications in you get diabetic retinopathy. the eyes, causes damage to the net retina of the eye, ischemic leakage and neovascularization. Types, non-proliferative. These ones, glucose gets in, they destroy the nerves, and then you get dot blood hemorrhage. Sometimes you have seen a person having an eye that is very white or red, and exudate cotton will they can be managed by surgeries. You see, sugars can destroy even the vision. New vessel formation. They start forming other vessels in your eyes because of the eye sugar, the eye sugar levels, and then you start bleeding inside the eye. That is losing vision. Hmm? The complications are you lose your vision. You lose your vision. You get it? You lose your vision. A minute. Yeah. What is happening here? You lose your vision because you lose your visions because just a minute someone needs to know something here. And then blindness. Blindness, you'll get blindness, which is not good thing. In diabetes, when you get those raw spots, you'll get blindness. Yeah? Other eye problems like diabetic macular edema, cataracts, and glaucoma. You get it? Yes. Yes, Simon. Plus wale wawili eh? Okay. Na kutumia lakini tutaongea na wewe nikimaliza kitu nafanya. Na kutumia then tutaongea nikimaliza kitu nafanya. Okay, sawa. Hai. Now we continue diabetic neuropathy. Diabetic neuropathy. Nephropathy, sorry. This is a complication. This is a complication that affects the kidney. Just a minute. Give me just a minute. Just a minute. Just a minute. Yes, yes, yes. Give me a minute. I sort these people what they need. And then we continue. Sometimes when you are multitasking, you can be doing this and then you get something else that you're supposed to do, and it's an emergency. Mostly when you're a doctor, you get so many issues. This is called Kiari. Just a minute, bear with me for those who are watching. I sort these people. Now, diabetic, we have key features when it comes to micro damages about the kidney. We have seen macro and micro. So when it comes to micro, what is there is, yes, when it comes to micro, what is there is you have small damage of the small vessels. You get it? The damage of the small vessels, which is very bad. What am I doing? Sorry about that. Okay, just a minute, guys. Just a minute. Now we will talk about two things that are very important: the eyes and your kidneys in diabetes. Now that when it comes to high sugar levels, you will get the problems of vessels growing inside your eyes. It is called diabetic retinopathy. Surgery can help at early stage, but you see, sometimes surgery cannot help at late stage. You see, non-proliferative microaneurysms dot blotted hemorrhages on your and exudate cotton wool spots, white spots in your eyes, proliferative retinopathy, new vessel formation in your eye, hmm? Neurovascular because of high sugar levels. And then we have something else here. We have something else like complication called proliferative retinopathy, the new vessel formation. But the complication will be you will have vision loss. You will have vision loss. Wait. You will have vision loss. Why? Because the vessels that are coming up, they are blocking your vision. The the sight, the perception of light and sight is being broken. So this one ends to blindness. Diabetic macular edema, cataract, you see, it ends to blindness and glaucoma. So here we can get another complication called diabetic nephropathy. This one affects the kidney, nephropathy, glomerular basement membrane thickening, mesangial expansion, glomerular sclerosis, the kidney. And now, what will you have? Microalbumin. Albumin will be in your, sorry, albumin will be in your urine because your kidneys are, sorry about, your kidneys are not filtering things well. Hmm? Microalbuminemia, more proteins or low proteins, progressive decline in filtering. Your kidneys will not filter well. You get it? This is called diabetic nephropathy. Now, this nephro talks about the kidney. The kidney, you see, Kinstel Wilson nodules in the glomerulus, in the kidney. So you start removing proteins, sodium, water, and this is how you become so hypo. You get down with your pressure because now your kidney is not balancing well. It can't keep water inside. It can't mix salts inside. You see, it's a problem. We call it nephropathy. Peripheral systemic polynephropathy, glove and Toshkin sensory loss, paresthesia, and burning sensation in your feet. Hmm? You have burning sensation in your feet after because now your kidney is not doing its job well. And then we have autonomic nephropathy, gastroparesis, erectile dysfunction. Imagine, hmm? You have gastroparesis and erectile dysfunction in men. Men that are having problems with diabetes. If you ask so much, you will find that their their engine sometimes never wakes up well because of nerve complication. You know, these things are controlled by nerves. So in bed, when your wife wants some nini, the EO, that thing, you cannot. And then there is gastroparesis. This is a chronic disorder of stomach motility. Food does not just go well in your stomach, it cannot go well. It is imbalanced. It stays long in your stomach because increte hormones are not relating well. You get it? Now, so erectile dysfunction, autonomic nephropathy, orthostatic hypotension, bladder dysfunction. You see, orthostatic. Sometimes you just get your blood pressure going down. You have erectile dysfunction. You get it? Focal neuropathies, cranial nerve pulses like cranial nerve 3. Cranial nerve 3 helps the eye. You get it? Pupils. They help the eye. So sometimes you may wake up and get your eye is not okay. You can't, the lid can't go up. That we call it ptosis. The lid can't go up. Those are called focal. So we can see high sugar levels can cause the damage in your eye by creating other blood vessels in your eye, causing you not to see well. And then diabetic nephropathy, kidneys damage. And then diabetic neuropathy, nerves, problems in the nerves. You see, So we will go to pathogenesis of microvascular. You see, chronic hyperglycemia, high sugar levels, they enhance non-enzymatic glycation. You have high sugars around your enzymes, and then they cannot speak well. They cannot pass messages well. Hmm? The accumulation slows your body to work. You get it? Now we have learned about micro and macro. Macro macro complications. I've said micro are small, like like the ones that affect the small vessels, but macro affects the heart, the kidneys. You get it. Now we go to macrovascular complications. You will start having cardiovascular diseases, increased risk of coronary artery disease, myocardial infarction, because there is no good oxygen supply in your heart. You see, high sugar levels, it is related to high infection rate. Your heart has a pumping power that if it is slowed down, some parts of your heart will die. We call it myocardial infarction. So if they die, what else? Your heart cannot pump well. So if it cannot pump well, what will happen? You will die. Cerebrovascular disease, like we have seen from the first stage, the diabetic ketoacidosis and HSS. Those two are bad things. It can lead to stroke. And then what will happen? You go to the ICU for long time. Maybe you will not come from the ICU. So monitoring your blood sugars and taking care of yourself is very important. And then you have peripheral arterial diseases, atherosclerosis of limb arteries, radiation, ischemia, ulcer, and gangrene. Gangrene is something that is rotten, a tissue in your body that is rotten. It should be cut to go away. Ischemic ulcers, claudiation. See, and then atherosclerosis of limb arteries. You said you have at your. I talked about it one day where you have things that are sedimenting in your arteries inside, so it reduces the volume of your artery. Or sometimes what happens is you have hard hard arteries. You get it? Other complications, those are like diabetic foot, infection, skins, and skin changes. Now, we have talked about very important things. We have categorized, there are some things that I'll talk to. Tomorrow, we are talking about diabetic mother. Why a mother becomes diabetic after giving birth or during birth, during pregnancy carrying. So we will talk about it tomorrow, and then there is come a time we'll talk about diabetic foot after that one, infection, skin changes, and dental issues. So today we have talked about two major issues: acute complication and chronic complication. So in acute complication, we have talked about diabetic ketoacidosis and hyperosmolar hyperglycemic state, the first one. And then we have talked about hypoglycemia, low sugar levels. In chronic, we have talked about micro complications like diabetic retinopathy that affects the eye and diabetic nephropathy that affects the kidney. If you have a question, you can place it up or we can talk to you about it next time. And then we have talked about diabetic neuropathy, microvascular ischemia, subtle accumulation in the nerves. You see, and then we have macrovascular complications that brings cardiovascular diseases, cerebral vascular diseases like stroke, and then peripheral arterial diseases, atherosclerosis. You see, so tomorrow, I think that people have no questions. Today it has been 49 minutes. You come with your questions tomorrow. We get to know why our mothers go to hospital to bear children and then they come diabetic, or when they have no diabetes during their pregnancy journey, they start having a mother who is diabetic. We will know about it tomorrow, and Last week I was not there from Friday. We were having several ABCDs. We met with some YouTubers and we talked. You saw that, and we will continue having these talks. So, if you have someone who is diabetic somewhere, you share these videos because these people suffer these things, and then they go to hospital. They are told it was an infection. They should know how these infections comes in and how it is relating. So, anyone with a question today? Anyone with a question? Anyone with a good question? I'm waiting to get a question from anyone. I'll give a chance to get a good morning from this. Anyone with a question? I see there is no question. Let's end that stream today here. We meet tomorrow to help our mothers who are diabetic in pregnancy. Stay cool, day, stay good. Bye.